We're at the witching hour. Good afternoon. I'm George Rutherford. I'm the acting executive director of the Institute for Global Health Sciences here at UCSF, and it's a pleasure to have all of you. Specifically, we're pleased to welcome the WHO Tech Task Force. We here at UCSF feel that we're at the cutting edge of using data and technology to improve patient care and public health surveillance. Between the Precision Medicine Initiative, the BACAR Computational Sciences Institute, the Center for Digital Health Information, our own Institute for Global Health Sciences, Informatics Hub, and the Chan Zuckerberg BioHub, we house some of the best data science and bioinformatics capacity in the world. The BioHub is also, the Chan Zuckerberg BioHub is also working with the Gates Foundation to make genomic sequencing capability more accessible in low and middle income countries. IGHS is also a CDC partner ad nauseum on several impactful initiatives related to electronic medical record packages in open MRS, national data warehouses, visualizations, and expanded program data used through applied analytics. Moreover, we're working with several academic partners in low and middle income countries to develop data science and modeling training programs to further leverage data to rapidly strengthen the public health system. So our focus is on data, our focus is on public health, at least speaking for the Institute for Global Health Sciences. Our focus is somewhat on clinical care, but we like to pull it all together with our basic science colleagues and our clinical colleagues. But anyway, it's a true pleasure to have all of you here. Old friends, John, great to see you. New people, welcome to San Francisco. It didn't used to look like this. This was a rundown warehouse district, and it's sort of sprung full blown from the brow of Zeus here in the last 10 years. That was a classical reference, by the way. So let me turn it over to Mary Pittman. Dr. Pittman is the president and CEO of the Public Health Institute and the chair of the board of the Bay Area Global Health Alliance. Mary and I go way, way back. And it's a pleasure to have you on campus. Thanks a lot, Mary.
Thank you.
And welcome.
Thanks so much. It's great to be here and see old friends, Andy, who I have not met before, John, who formerly was a PHI person, and George and I do go way, way back. So, and it's good to have all of you here today. One of the, just a little bit about the Public Health Institute, and I think George said I'm chair of the board of the Bay Area Health Alliance. I was one of the founder groups that brought together with academics and with some of the tech companies the idea of the alliance. And one of the reasons we did that, the Public Health Institute is a freestanding nonprofit that is a little bit unique in the country. We're not affiliated with government or with any academic center. And we do a lot of domestic work, but we also have done global work for about 40 years. And it was hard for us to find colleagues in the Bay Area to partner with on a lot of the work that we were doing. And so we were really enthusiastic. Let's find some partners that we can work together with. And the Bay Area Global Health Alliance is the answer to having to ask the question, how do we find people and bring them together? I just want to tell you a little bit about who we are and what makes us unique and what we do. The Alliance is a unique global health organization, but more than that, it's a community, and it's a community of more than 60 member organizations that span academia, and I'll have to say world-class academia. Just look at where we're sitting right now, and experienced nonprofits who are caring for the most vulnerable populations around the globe. Innovative technology, biotech, and pharmaceutical companies, and knowledge management companies. I think what we look at as tech is continuing to grow and evolve, and we're a welcome place to bring all of those different sectors together. And what we do is build close collaborative partnerships and relationships and find the collective intelligence across these different diverse components of the community to advance health equity and impact and leverage and really strengthen the innovation ethos that exists in each of these separate sectors and organizations. All of our work that we try to do is through an equity lens as well. It's another unique element, I think, of this collective alliance. Over the last 2 years, with strong membership and leadership support, I'm going to just read a couple of the points that Sarah shared for me. We've been able to build bridges and networks and are starting to see a transformation now of how these diverse sectors are working together. We do serve as a neutral convener, like today. We broker multi-sector collaborations and engage the tech sector alongside traditional health stakeholders. We've been able to foster some really interesting partnerships and are very pleased to serve as a secretariat for the WHO Tech Task Force and the task force led by Andy Pattison, team lead for digital channels. He's joined today by Dr. Garrett Mehl, who is the head of digital health technology, and Dr. John Grove, who's director of quality assurance norms and standards. And so for those of you who are interested, if you go to the Bay Area Global Health Alliance website, we have many different educational opportunities and forums similar to this, and we welcome you joining us in the future. And now I'm going to hand it off to Andy.
Dr. John Grove will give a presentation about the Science Division. Dr. Garrett Mehl will give a presentation about digital health innovation. And I'll come in at the end to tell you about the work that we're doing with the Tech Task Force and working with the technology sector in general. So, John, if I can hand it to you.
Thanks so much. And thanks, George and Mary. And it's great to see so many friends and people I had even forgotten or didn't even know where they were, getting to see them come out today. So thanks so much. And we're really enjoying our visit here out to the American West. And of course, could not resist the chance to come to UCSF and spend some time with you today. What I'm going to do is just give you probably more of a high level view on what's going on within WHO when it comes to how we're trying to pull together the different threads that need to come together for us to respond more actively as a multilateral organization. And much of this was being put in place even before COVID. So there was this big push for transformation, and then COVID came along and accelerated a lot of a lot of the work that we were already starting to do, but really made it much more high demand that we move fast and furiously ahead. And so it's been a test case of also pulling this division together and some of the different threads. The Science Division. Let's see if I've got the clicker going. Is it the red button? Anybody know? Nope. Spacebar. Clicker. Right arrow. Oi, okay.
I'm so glad you went first with the slide.
Well, and I'm glad no one noticed that I had the year 2020 on my front slide. So, okay, and I don't want to go through those years again, but anyway. The Science Division, our vision is to harness the power of science and innovation to support our member states and to achieve the health-related SDGs, and also to support the emergency preparedness and response. As many of you know, we're a member state organization. We're a multilateral organization. And so all that we do is really all about creating a level playing field and getting the best of science to everyone who needs it. And so our mission is to really provide the global leadership around that and translating the latest science, evidence, and innovation and digital solutions to improve health and health equity for all. We are, as I said, accountable to our member states. We are also uniquely positioned to have a sense of what the country needs are, and also to hear and to be guided by the global guidance that we are tasked with developing. And so all those pieces need to come together. There's some evaluations that were done early on in 2016, 2017, specifically looking at the Ebola response, but also looking at our normative and standard setting products. And it should maybe not a surprise to many of you, but there was much feedback that these things were coming out of various departments at various times, and sometimes with
conflicting messaging, conflicting recommendations. And so we took the opportunity during the transformation to essentially aim to centralize a number of these functions so that WHO is more consistent, so that we're more focused on the impact for the field level, and that we're really upping our game when it comes to bringing technology solutions to the discussion. So the science division was formed. The chief scientist is Dr. Soumya Swaminathan. She's our big boss, and she reports to, well, Dr. Tedros is our big boss, and then there's Soumya, and then we have our departments. It's a number of departments and what we call hosted entities. So in terms of departments, we have 3 new departments. So one is the Quality Assurance Norms and Standards Department, which is the one that I lead. Within that group, we have a Methods and Standards unit, a Process Efficiency unit, Product Design and Impact, the Office of the Publisher, WHO Library, and a team called Governance and Review Services, which handles all of the accreditation for expert committees and collaborating centers. So the whole idea is to bring together all of the end-to-end pieces necessary to produce an evidence-based, highly impactful, useful WHO normative and standard setting product. We also have the Digital Health and Innovation Department. This is where Garrett and Andy are both sitting. They're focusing on strategy and governance, public health, tech and digital technology, capacity building, a specific project around Be Healthy, Be Mobile for physical activity. Innovation Hub, looking to do matchmaking between groups providing new innovations and countries that are asking for those innovations, and the digital channels team, which Andy is leading. And then we have the 3 hosted entities, the Alliance for Public Health Systems Research, TDR, who I'm sure many of you know of, and also the Human Reproduction Program. We have another department that we formed called Research for Health. This brings together a number of functions around looking at the emerging technologies, a foresight mechanism to see what's going on in the R&D space, what are the things we need to be aware of to get ready to bring into the global ecosystem. This is where our health ethics and governance work fits. We also have an evidence to policy and impact unit, and also similar to my department, QNS, also very much engaged in coordination and prioritization of research across the house. So this is a broad view of the division. We're relatively new. 2019 is when it all began, and then of course not long after pulled right into COVID. But had it not been for some of these pieces being brought together, I actually don't think we would have responded as well as we did as an organization. And you'll hear some examples today from my colleagues as well on that. So this is our log frame. You have to have one of these, of course, in global health, but it does actually represent a number of cross-cutting areas. So this doesn't give you a portrayal of by department, but gives you an idea of what some of the cross-cutting thrusts within the division are. And so a big one is what we call the living approach to guidance development in normative and standard setting products, which includes the digital channels work of putting things into a form where people can actually understand, and the messaging required to do that based on WHO recommendations. And also our digital health work, where we're looking at the delivery end and also the computable, how we can make those guidelines more computable and accessible to people, and right in the palm of their hand or right in front of their computer screen, and leapfrogging from writing tomes and tomes of more academic sounding kinds of guidance, and really getting the information to the people that need it as soon as possible. I described for you the transformation process, basically this decision to pull all of these pieces together for a much more centralized approach. I won't go too much further into my department goals, as I think I've explained it. We're solving for a number of problems. I think many of you know that WHO guidelines can take different amounts of time to get out, and so we've actually dug pretty deep to see just how long those things are taking. And I do have a slide that actually names which guideline And I only use that for internal audiences only. When we point out that there's one that took 1,049 days to complete. But there are any number of factors that play on why a guideline would take so long. Sometimes the data isn't available. Sometimes there are a number of questions that have been raised. Sometimes the group put something forward and they ended up not having the funding to carry it through. There are many reasons, but we've dug very deeply into what are the delays in those processes and what are the things we need to put in place to better support the development of that work. Another thing is the new reality of time, and we saw this during COVID. We moved from a mode where we take 3 to 5 to 6 to 12 months to develop recommendation and guidance to a point where, sorry, we need that recommendation today. And that's fueled very much by the pandemic, of course, but other factors like just how fast technology is moving, how much faster science and research is being done. So evidence is coming forward all the time, and we really need to rewire the system to be able to handle that much more appropriately. So we're incorporating a living approach where we're trying to get a better sense of the evidence that's coming from the upstream, that we're putting tools in place to update that as it's coming through, and then working, as I said, on more immediate delivery and appropriate formats to people in the field. Another thing that we're solving for is this issue. I think those of us who are tech savvy, those of us who are in nice offices or working from our nice apartments and houses, maybe our desks don't look like this as much, but when you're sitting in a country office somewhere and you're being deluged with information and guidance coming at you, we really need to be much better about this. And given that WHO produces, well, in this biennium, we will produce probably around 3,000 normative and standard setting products that come from about 800 core products. So there's a core set of things we're working on. There are many derivatives, but we need to put those in a format where people can easily get right to what is it do I need to do in terms of changing my practice. So we're doing a number of things around this. I'll try to go quickly through this. One is the unpacking what is taking us so long. So we use COVID as a chance to set up some new systems. For the COVID therapeutics work, if you go onto our website, you'll see that it's a living guideline now. We had a guidance development group that was staged and ready to go. We had a group of people who were surveilling the evidence and literature and making sure we had all the trials and information and putting all that through a system that shortened things from weeks and months to days. We also set up a committee that would allow us to take interim guidance and make it available to the world in a 48-hour turnaround if we felt that the science was good enough to put out to the world from a precautionary perspective. We've also worked across the organization to put in agreed quality assurance criteria. So all of our technical products coming through the system need to focus on the robustness of the process. Have we included the stakeholders? What are the methods that we have brought to those products? The presentation, is it accessible? Has it been translated, and has it been designed with impact in mind? We're also putting a number of things in place to, again, leverage technology. We've just invested in a new best-in-class publishing system. We're experimenting with a couple of platforms to do the living guidance and adaptation. So the global development of guidance, as well as being able to engage experts from across the globe in the authoring and development of that guidance, and then also recommendation repositories. We have thousands of recommendations we make over time, and to be able to access those and all of the information behind them. Garrett will go into this work a bit more, but there's different layers we're looking at in terms of how and when is it appropriate to quickly move towards a computable kind of approach with a specific recommendation or tool or package. And so we have developed a set of design standards and handoff points with his team to take it from the sort of out of the workshop, from the, we call it from the Pico question to the palm. We're also working on a WHO technical package for countries. So we know the technology is important, but what are all the human and health systems aspects of things when we need to introduce a guideline? Do we need to get the medical school involved? Do we need to find out who's making decisions at the Ministry of Health on making a decision around something? We've done a lot of work in Ukraine, which unfortunately is literally up in smoke at the moment, but we worked with them to prioritize what guidelines they were going to update and how they were going to make those adjustments on the ground. So this is what we've been engaged in over the last couple of years. I'll go quickly through this as well, but we've had some success with these new systems. We've put in place new practices, and the quality assurance benchmarking has been applied to all of the different technical products that have come through. WHO is now prioritizing what we call technical products. So we have the 800 that are planned for this biennium, and that's region, country, and headquarters planned products. So our team is facilitating and supporting those processes, and we've developed dashboards so that when a member state calls, India calls and says, hey, how come you haven't put the new yoga app out yet? We can go to this dashboard and find out what's taking so long and why it's not moving forward. And we're monitoring that and doing all of the follow-up with the various teams. We also, I'm very careful to say when we talk about quality assurance, not to say that WHO hasn't been doing quality work for the last 70 years. I've had department directors and people say, are you trying to say that what we haven't been doing is quality? We've, of course, been doing brilliant things, but we've not been doing it at a consistent standard. And so putting in place the checklists, the standards, and also capacity building mechanisms to help bring as much support to those processes as we can. And the quality checkpoints across this are, as I've outlined already. We've incorporated this living guidelines approach, specifically with the therapeutics, which I mentioned, and we have moved towards more digitally structured and digitally enabled content and access to materials. Garrett will go more into the SMART guidelines. Just what might be of interest for all of you is we have formed what we call the Evidence Collaborative for COVID-19. It's a monthly call, a global phone call that we do where we share notes. We have Cochrane, we have Campbell, we have the COVID End project, and then about 100 different institutions that are all engaged in either evidence retrieval and analysis for COVID-19 or those doing systematic reviews and engaging in guidance development. And so that's something you're all welcome to be a part of. We also have the COVID-19 open research database where we called upon various libraries across the world to all pool their content into a single place. And actually, we've got more than 700,000 open access citations at this stage with 6,000 active users per day. The rapid mechanism I talked about, we process now about 2,000 different pieces of interim guidance during the emergency phase. This is a group of people that work day and night looking at these documents and make sure we're not coming out with inconsistent messaging. We've also been experimenting, as I said, with recommendations repository. We also have an active system of rapid reviews happening with our rapid review group and all of the partners in the ECC 19, which I mentioned. But the big push for us now is to really say, what have we learned from this experience and how can we take some of these new muscles that we've built and make it part of how we do business going forward. And so a big focus for us the next 2 years is really around the living approach and extending these platforms, and not necessarily the speed always that we have had to use with the emergency, but certainly the diligence and the paying attention to the robustness, the new systems, and the redoubled support to improve what we produce. So I think I'll stop there actually, but that's a bit of an overview. It's gives you a sense of the division. It gives you a sense of really what is our core piece of bread and butter, and that WHO is all about recommendations and all about norms and standards. And so I think now we turn it over to Garrett, who will take you a bit further into some of the more digital health oriented pieces of that. And then we'll hear from Andy on the messaging and channels. Okay, so thanks all.
Very nice. Thanks so much. It's a pleasure to be here. It's a real honor. I'll provide a little bit of an overview of the Department of Digital Health and Innovations, where Andy and I sit, and give you a little bit of an overview of work that we're focused on, and hopefully that will trigger some new discussions and collaborations. So I want to maybe just within the science division, the digital health and innovations department, I think John gave a nice overview of the different units that are part of that. But at a maybe at a high level, we focus on both innovations and also separately on the area of digital health. And we are trying to ensure that countries have the capacity, the technical tools, the guidance, and also the coordinated technical support and financing to ensure that they're able to successfully adopt, leverage, and bring innovations as well as digital health approaches to bear to strengthen their health systems. We're very much guided by, at least on the digital health side, the global digital health strategy. And we have parts of the department that focus on country capacity building, ensuring that there's enabling environment, as well as countries are able to go through a planning process of defining where they're at and understanding where they're trying to go so they can plan and architect for that future. We also, as part of both to support countries as well as to support our partners across the organization, we also establish standards for and criteria for assessment, including guidance around how to synthesize and ensure that there is evidence-based guideline recommendations available to countries around what evidence is supportive of different uses of digital health, including about how to implement those systems as well. There's very much a focus on as well ensuring that clinical public health and data recommendations are synthesized and brought to bear both for clinical and health provider systems as well as those that patients are using, including the work that Andy does on digital channels. There's the matchmaking on innovations and ensuring that countries are defining their needs and helping to source innovations from the different pipeline of innovations that are coming out of countries, as well as innovators outside of their regions. And we very much also focus on ensuring that there is a learning ecosystem. The Innovation Hub is one strong focus of the department, and that is very much around understanding the demand from countries, understanding the supply of innovations that are coming out of these pipelines, and then ensuring that there is a matchmaking that happens between those two different constituencies and ensuring that innovations are appropriate and have an evidence base behind them so that countries can adopt and bring those to scale within countries, and that there's the financing to make it possible. And there is a focus as well on showcasing those innovations as part of a Eureka new innovation center that's being established at WHO that is about showcasing and helping to facilitate scale and understanding of those innovations. In the area of digital health, our North Star is very much the global strategy on digital health, which emerged out of the 2018 World Health Assembly resolution on digital health, which defined the need for both a global strategy as well as a new department, which was formed in 2019. And the four areas that are of focus that are important are around global collaboration and ensuring that we're all different parts, all different sectors are engaged in helping a country adopt and mature and use digital health. The second is really about ensuring that countries have strategies and that they have the policy and enabling environment. The third is really focused on governance at all different levels, including at the country level, to ensure that accountability and due process is brought to bear on the investments and the implementation of the of digital health. And then lastly is the systems that are people or person-centered and that really focus on continuity of care and quality and ensuring that systems are interoperable and that they are helping to augment the systems themselves. I just want to highlight a few areas of work in the department. One is an area that's emerging around ensuring that countries have the ability to assess where they're at in terms of their digital capabilities at a national level, and then in assessing that in a consistent way. That will be linked to how the global digital health strategy focuses on 174 different actions that are encouraged by different stakeholders, including countries, and ensuring that there is a consistent way of assessing a country and where they're at so that they can progress to a higher state of maturity. A second area that has been really understanding the role and value of AI and ensuring that there's guidance available to countries that ensures that they're able to get the most out of and understand AI, that it is guided by ethics and has a governance framework part of that. There is as well a focus on ensuring that we understand how we will apply a consistent way to review and assess those software and medical devices that have AI, and that there has been established a focus group that some of you may be familiar with ITU, that is an open focus group, and you're welcome to join, but focuses on the different aspects of both cataloging and curating and benchmarking different use cases of AI. There's a training course that's being developed, as well as different regulatory concepts that will be part of guidance that's coming out soon, and a broader initiative in that area. Part of my colleagues in other parts of the organization also focus on training and ensuring that there is an understanding of the different aspects that a Ministry of Health or an implementing partner will need to have, the core knowledge and foundations. There's a fantastic course that many of you may be familiar with and is being expanded considerably, and we would very much welcome those who would like to partner in those areas. But it is a training course that takes place over over about 10 or 15 days, that enables those who need to know foundational pieces in how to use digital health and how to invest and how to make the most of it, that they have the capacity to do so through such a training course. When we, in 2018, when the resolution on digital health was announced, we recognized that we needed to, and we were encouraged to develop guidelines on digital health. And we conducted a series of systematic reviews that led to 10 different recommendations for functionalities in digital health. So things like digital decision support, as well as messaging and other functionalities that you typically see. There were, within that, there were about 85 different uses that we identified in digital health, but the recommendations themselves focused on the 10 that had the greatest evidence base. And I would just note, being in an academic environment, I would just encourage those of you who are not familiar yet with the classifications of digital health interventions to have a look at that if you are doing work and research in the area of digital health, so you can look at the units of analysis that form the basis of the guidelines and any research that would then need to be done in order to help us to develop better recommendations in this area. There was an unfortunate lack of evidence in some areas and robust evidence, but alongside the 10 recommendations that were released in the guideline in 2019, we then subsequently developed an implementation guide called the Digital Implementation Investment Guide, which was done with colleagues at PATH, as well as UNFPA and UNICEF, which really helps a country go through 9 different steps to know how to apply digital health for the purposes of their national digital health programs, as well as acknowledging that there are cross-sectoral elements, and the output of which is a costed implementation plan that they can then take to their financing in their own governments, or go to donors and ensure that they get the financing that's needed. I'll just briefly mention the area of smart guidelines and the work that is really about taking and understanding that there are these up to 40 different guideline documents that are released every year by WHO that make recommendations around clinical public health and data practice. and that we were aware of the challenges from going from the recommendations into digital systems, and in helping facilitate that in a consistent way meant that we had to establish a systematic process of establishing what the content would look like. And we borrowed from work that had been done at CDC to adapt an entire framework for a systematic determination, content specification around looking at the narrative recommendations as this level one, and then going to subsequent layers of the functional requirements for what a system or a digital application would need to do functionally is the layer two. L3 is really the standards, including the ICD codes and FHIR content and the clinical quality language. So the algorithms defined in a machine readable way. John has mentioned them as computable guidelines. That's the L3. And then the systems that themselves are consistent with the recommendations as reference software. That's the L4, that are executable, that you actually have in the palm of your hand and are able to use them. The L5, we assume that as systems evolve to include this content, there'll be a consistent data set that will enable optimization of algorithms, and that it will be a dynamic, and we will have optimized algorithms for clinical decision support in other areas. And these are sort of examples from the antenatal care area, going from the L1 through the L4 and what they look like. They are essentially all saying the same thing. They're just doing it in different ways. And for those who are developing digital systems, the L3 really relates to the use of FHIR implementation guides and the core content in an executable format. And we are trying to make it easier for developers in low-income countries to be able to build systems that are consistent with what WHO recommends. And that process of getting the SMART guidelines, that 5-layer out to countries will really need to be enabled by the donor community, as well as the different partners that help facilitate countries to adopt digital systems. And there's a whole ecosystem approach that we are working on. And to enable that, there's very much a technology ecosystem that's going to be required, both on the upstream as well as the downstream. And I just assumed that there would be some in the audience that would be interested about the different components of that ecosystem. And this is very much aligned with the 5 layers of the SMART guidelines, but it is about the upstream, ensuring that we can author SMART guidelines, and the downstream is ensuring that there's an ecosystem of technology partners who can build systems that are enabled by and using FHIR, CQL, and ICD codes, and that are fully executable. Products that meet and ensure that they are consistent with WHO recommendations and specifications will then be shared and curated in a clearinghouse. We'll have a sandboxing environment and a set of criteria that we'll assess those products against. And then we'll make sure that just a little bit like the essential drugs, we're able to ensure that there's a market shaping that helps to facilitate those who have products that are consistent with what we recommend, that we make those available, and that countries are then aware of them so they can adopt them. And I'll end there. Thank you very much.
I'm just going to tell you a little bit about what we do in my team and what we try to achieve, and then tell you about 2 or 3 projects that we do. I'll only go to talk about 2 or 3 of the 130 projects we've pulled together with the tech industry in the last 2 years since the beginning of the pandemic. Our first project was in February 2020, so really soon after the public health emergency of international concern was declared. So our job in our team is to get more health messages to more people through more channels, so that they can make better health decisions and hopefully live healthier lives. We do this in 3 pillars of work. The first pillar is to raise good content. Misinformation thrives in a vacuum, so we really want to get that content into people's lives. And when we say raise content, my team don't just look at WHO, we're thinking public health in general. So we're raising our own content, ministries of health content, but also some key partners, UNICEF and key people like that. We focus, when we think about our projects, we focus on three key demographics, three populations. The first group are people like you and me here today. We call them the hyper-connected. Those are people with multiple screens, who have easy connection to the internet and don't really mind about data costs that much. Yes, we do complain about our price of our packages, but once we've bought them, we go off and we just are constantly connected. Hyper-connected people exist in every single community and in every single profession. It is no longer a north-south divide. There are fishermen in very poor communities who are hyper-connected. What we've seen is, we'll come to that in a minute, the other two groups also exist in very rich countries. The second group of people are people who have access to the internet with multiple devices, but may have connectivity issues because their bandwidth is very small or short or light or temperamental, but they also have cost issues, data issues. And that's a group of people that we care tremendously about because they're also vulnerable populations. The third group of people that we consider when we do our projects are people who are connected to a network of some kind through a dumb phone or feature phone, as they say, and maybe a SIM card. And those are possibly the most vulnerable people who are connected in our world today. So we try and look at those three different audiences when we consider projects. And it's easy to find projects in the hyper-connected. Everyone's doing that, right? Everyone's connected and working in there, and every day you're getting health messages through those. It's a lot harder to focus on the other ones. So today I'll tell you a few of those projects which end up in serving populations who are most vulnerable. And what I mentioned with regards to hyper-connected being in every walk of life and every industry and every country, the same is true for the very vulnerable people. We see in very rich countries, my own, the UK, and where we are today, the US, as prime examples, extremely poor people in communities who should have access to the internet and should have access to health information to make better health decisions, who simply don't or who struggle. So what we try to do is, rather than change people's behavior, their digital journey, for want of a better word, we try and reach them where they are. So on your average mobile phone, industry standards tell me that we have 30 apps minimum. We swap them on and off. And actually every day we really use 4. Whatever 4 on your phone are the ones that I want to be in. So we've had weird and wonderful collaborations with huge giants such as Facebook and Google, all the way down to tiny people, but quite quirky, like Tinder and things like that. We're trying to turn up in people's lives. I think as the pandemic progressed, we realized people are very difficult to reach with meaningful messages. And we have to innovate, completely rethink the way public health messaging does their work. People are sick of COVID, right? We all are. We're all sick of COVID messages. If you don't know by now and you're connected what you need to do to protect yourself and your family, there's a problem there. So what we try and do in my team is also innovate. So either be extremely specific. Young women who game and stream live on Twitch, they will resonate with messages which are geared and targeted towards them in an environment that they're interested in and existing are already in that space. So that's what we try and do. We try and innovate with very specific messages to targeted populations, or we try and surprise. And the example with Tinder is a perfect example where when people are looking for love in all the right places, they come across WHO message saying, well, when you are doing that, don't forget to stay safe, test, stay at home if you're sick, wear a mask as necessary, things like that. And when it comes to delivering content in people's digital journeys, it's important that we reach them in the palm of their hands, as John was saying, but also in the language which they are used to. And when I say language, it's not just the languages which are coming up on the board. It is like English, French, and German, things like that, but also the language that they are accustomed to. And by that, I mean, if they are following influencers, they want to hear the voice rather than the language of the person. So in a message that's attuned to what they're used to listening to. You can imagine that we don't say the same message to a middle-aged British man like myself and a 18-year-old Filipino gamer, we just don't say the same message. We have to have a different voice in that. So I'm going to tell you about 2 or 3 of our projects in this space. I'm going to start with one of the things which I think is the most impactful work that we do, and that's the work that we do behind the scenes with social media and digital companies with their policies and guidelines. And so what we do with them is week in, week out, we meet with these companies virtually, and we advise their policy, security, safety teams, or whatever they call themselves, on their policies, and we try and get them to improve their policies so that their platforms become a safer ecosystem for their users. And we all want healthier users. They want healthy user experiences. We want literally healthy users. So there's a lot of overlap. We've worked with all the big social media companies. We're going to build a platform of claims in the coming months so that everyone can access to it, because we have small teams. We can only cater to a certain number of companies. But just to give you an idea of what that means with some of these things, is these numbers are a little bit old, but over 1 million videos on YouTube have been removed thanks to the policies that we're encouraging YouTube to make a difference. 64 debunked claims doesn't sound a lot for Meta, but that's hundreds of thousands, if not millions, of messages that have been deleted, that have been reduced, or that have been flagged as not being correct. One of the cool things that we encourage Meta to do, for example, is when somebody has been exposed to misinformation, that they get a message afterwards to say, oh, by the way, you were exposed to misinformation, and this is why. So that will reappear in their feed. And earlier Jeremy mentioned to us something about bots. So I thought I'd quickly chuck in something about some of the chatbots we've done. We've got 10 plus chatbots at WHO. And this is a very interesting project for us because we're reaching some of the poor demographics that we mentioned. People who have low bandwidth can use chatbots and do use chatbots. People who have problems with price of data do use chatbots as a major source of communication. And there's hundreds of millions of people on all the chatbots already. So we want to, again, turn up in their lives while they're on the app. Suddenly somebody forwards something from WHO, you click on a link, and boom, you're into our chatbot experience and can engage on how to keep yourself and your family safe during times of COVID. So we got it on all the platforms that we think are relevant at the moment. We're looking into other ones. As we move away from COVID into other health topics, we are trying to figure out ways of using different channels to reach different populations on the health topics, which will help them live healthier lives. Where we talk about numbers in my team, no one quite believes us in the organization. And to give you that perspective, we talk about millions and billions when we talk about public health, right? But actually, it's quite interesting just to take a few moments and think about the scale of those two words. 1 million seconds, as you may know, is 12 days. 1 billion second is 31 years. It's a big difference between the two. But in public health and messaging, especially, we talk about millions reached or billions. My team is reaching billions of people through these messaging. An extra cool project that we've launched is the Free Basics. Free Basics is a mobile internet service which allows people to have access to health information for free data. So we work with the telecommunications unions and Meta, and Facebook, it's called Facebook Free Basics originally, to provide in over 180 countries this content. This is the stats we get from this project is where we know that there are very poor people living in extremely rich countries and have data connectivity problems. We have huge populations in first tier worlds accessing this. So again, our team no longer thinks of low middle income countries, but low middle income communities. And that's really important for us. Again, in that lowest form, so when we do our projects, our 130 projects that we've done, most of them are hyperconnected. And then there's very few in these spaces at the bottom for the most vulnerable people. This is one of those projects. We work with an organization called VMO to give voice messaging. So when, like when you phone your bank, it says press 1 for banking, press 2 to cancel your cards, press 3 to this. This is a similar kind of service. It's a toll-free number that they call. They get health messages in dozens of languages across mostly African region. And they only need a network and a SIM card, and a feature phone to access this information. This also hits another very vulnerable demographic, is the illiterate. So they can just listen to things. And we've had quite a lot of success with this project. Again, what we're looking at is, where do we expand from COVID now? We're going already with these projects into mental health, healthy living, physical activity, diet, and things like that. But of course, our chatbots also include pretty cool stuff. We've got some humanoid chatbots, which I'd encourage you to go out and try. We found that this uses a combination of humanoid 3D features, but also AI. You put your camera on and the AI works on mobile or desktop. The AI will read your face and respond accordingly. So if you're in a grumpy mood, it will say, "Are you okay? You look sad today," or "How can we help you?" A lot of scope in this space. We want to be in the metaverse when Meta arrives there. We want to get there first, so that when people get there, we can actually start servicing them with healthcare promotions. My vision is to have some kind of online metaverse healthcare facility where we can start triaging people into the right services, into the right healthcare, to the right healthcare providers, so they can get the best possible healthcare information and services. One of ours is Florence. Her face will change by the time you go on, because this was our first version of her. But we are reaching people to help them stop the use of tobacco. We launch our World No Tobacco project tomorrow, over the next 2 weeks, leading up to the 30th of May is World No Tobacco Day. So good time to talk about quitting tobacco. In fact, COVID, there's never been a better time with COVID to stop smoking, right? Because it's the risks are even higher. I just want to end by saying that, how do we do this? I basically have convened a tech task force. So in February 2020, I flew over to the Bay Area, convened a tech task force. So all the technology companies in the Bay Area to come. We invited them to a space, and we sat next to each other with no masks in a busy room, 30 people with no ventilation the whole day, because the guidance wasn't yet out about that. And we sat there brainstorming about how we were going to stop this respiratory disease and the misinformation that would follow. So it's quite funny thinking back to those days, and it's a little bit surreal. But we were able to pull together, there's now some 60 companies, all the big ones are there. We regularly, the first one was in person, of course, after that it's been virtual. Just on Monday, I held my second in real life event at the LinkedIn offices down in near that's right, down in the Bay Area. And we couldn't do it without our friends Sarah and the Bay Area Global Health Alliance, who act as our secretariat to help us pull them all together. What we've seen is an incredible movement in the tech industry. And I'll just end with this one last example of a project we did with Uber. I'm sure you're all familiar with Uber. Early on in the pandemic, we released data on the most vulnerable populations in society. And in the West, that was taxi drivers and security guards. They were the ones, taxi drivers, bus drivers, drivers in general of populations, and security guards. And that's because they were in contact with hundreds of people a day. And Uber read that. We presented it at Tech Task Force. Uber read it and said, "This is terrible. What can we do to protect our drivers? Let's jump on a call." We had a call with them. We encouraged them to create guidance for their drivers and delivery people. We worked with them, with their health team, with their safety and security team. We built guidance. We released that guidance. They changed their app. So now when you get into an Uber, you have to say, "I am going to wear a mask," right? That's because of the work we did with Uber. The drivers themselves have to take a picture of themselves in a mask before they can start service. And all these features that they put in, well, so we drag them into our sort of business model of what needs to happen. The great thing about this is, without giving competitive advantage to Uber, we put in this sort of clause in our business relationship with them to say, everything you do is for global good and has to be released to the world. When we presented that, again, back to the Tech Task Force about 4 weeks later, and that they started rolling it out at Uber, the Perspex glass that you see, everything you see in those cabs is thanks to the work that we did. They cracked the windows and started talking about ventilation. And I said to my scientists, "What do you think about this?" And they were like, "We're already working on the ventilation guidance. It's coming out next week." So really everybody's in sync in this space. What happened when we presented it back to the Tech Task Force, Lyft, Bolt, and other taxi companies went, we're having some of that. And that's what we've done to protect people. And the technology industry have been able to save literally hundreds of lives. So very cool that as a group of people, we've actually had a really big impact on that. I shall end there, and thank you for your time. Of course, we're happy to take questions. We'd be delighted to start conversations.
I also just wanted to say really quickly, we have on our trip today, we have, or this week, we have Taya, who can pronounce her last name. Taya. She just always says Taya, who's the creative lead with Andy's team. And we also have Jamie Voss, who's with the WHO Foundation, traveling with us as well. The WHO Foundation is a new foundation set up to help us engage more creatively with the private sector, and also to work with some non-traditional partners where we, as WHO, we've been quite restricted in the past. So just wanted people to know that Jamie's here and Taya's here also.
The work you've done with digital channels targeting consumers, patients, people is really remarkable and seems to be very effective. How does this apply to healthcare professionals? Is WHO thinking about revamping the way it communicates to healthcare professionals to provide education and guidance, or is that going to be handled differently?
It's a very good question. Actually, our support to healthcare workers is super important. You know, as you know, in a lot of countries, we have a massive gap of human resources in nursing, midwifery, and doctors. Anywhere in actually in human resources in the healthcare sector, and of course, data science as well. You know, is going to be a big gap in a lot of countries. We just in my team, I only speak for my team. We've created an operation Fides. Fides is the Greek and god of truth, and we thought that was quite a good name for them. We pulled together 100 healthcare professionals who are already active on social media, and every week we send them some talking points of what WHO thinks is top of mind, and we encourage them to create their own content. So in one small way, we're trying to make their lives easier because they're all out there fighting misinformation or trying to make their own communities healthier. And we're trying to give them ammunition, talking points to make their lives easier, and also think about public health as a global issue and not just a local issue, right? So that's in one capacity. My team is also working with the University of Arizona and the University of Toronto to create content and e-learning modules to train healthcare workers on how to speak to their patients about misinformation. So we're trying to educate them in digital literacy in that shape and form. And digital literacy is maybe the third element, and that goes beyond healthcare workers. My generation, we knew a good source of information, right? I knew that BBC, CNN, Al Jazeera's of the world were good sources of information. The next generation, my children, they don't have that. They just look at these slick videos with 25 million views, with cool music and cool people and great comments, and think, well, that must be true, right? Because of their videos are brilliant, but the content might not be. Whereas public health generally is very traditional and quite boring. I ask my kids what they think, and they're like, oh my God, you guys are so boring. You know, why don't you do something, you know, what Moonshine is doing on Twitch? And you're like, who the hell is that, right? So we need to also modernize the way we communicate. And I think digital tools and algorithms and mechanisms allow us to target specific people. And final to your point, John brought up an excellent point on Monday in our meeting with LinkedIn, would be to get help from a company like LinkedIn to help create better networking and more people to get into the public health space where we've got those gaps. You know, LinkedIn is seen as a recruitment tool, an HR tool. How can we get those people better connected? So those are the challenges we give the tech industry. We think that sort of the business to business of healthcare workers is really good. And if I can use just one example, we will be meeting a company called Kinsa Health, which is a local company in 10 minutes or so. And they've got connected thermometers. Working with them early in the pandemic, we reached their 2,000 to 3,000 nurses who are all nurses of high schools to give them information by educating them about what was happening with our guidance with regards to COVID. They would then put in the appropriate guidance within the schools. So that's the kind of way we're looking. We're a very small team, so we always want to do more. We're greedy and needy and pushy and nudgy with the tech industry. But we've got good content, they've got the reach. So when it comes to digital literacy, we've launched a series of Kahoots, which is an online learning course, and we want to get into that space. We have the WHO Academy, which is being built at the moment, and that's geared towards educating and building capacity with healthcare workers. So I hope that answers your question. It is a tricky one.
Are there any further questions? Yes, please.
Hi, thanks for the great presentations. I'm Josh Bress. I work in clinical decision support software. So my question is for Dr. Mehl about L1 to L5 and narratives. Something we've observed in our own work is how do you capture in an app something that would never be in the narrative? And how do we make sure we don't sort of make a Google Maps that was derived from a paper map that doesn't have all the great functionalities? So maybe we can think about, do you ever envision a day where there is no L1? That's my question. Thanks.
Interesting. Sorry, it's an interesting question. So maybe just to note, so there as WHO, even though we release maybe 30 to 40 guidelines with upwards of 25 recommendations each year that encompass hundreds of recommendations, what we're realizing in going through that process of going from L1 to L2 to L3 is that there are gaps. And especially as you're thinking through the operationalization of what does a decision support tool look like, that require looking at the guidance documents, which are typically focused on implementation, and how do you translate what is a recommendation into clinical or public health practice. I know, and so I think it has been what we have been doing is putting together groups that are subject matter experts to in going through that process of looking at the content and helping to ensure that it is, I would say, adequately just documented in such a way that those who are developing clinical decision support tools are able to do that. That's one, that is not what you're asked. And so I wanted to maybe just put that context to say we're recognizing there are gaps in that, and we're trying to ensure that we bring all the different content to bear and the processes that can be that will help to ensure that the gaps can be filled. I think the other point I think you're making is that we're interested in specific outcomes, and there are practices that may not have a recommendation behind them that through patterns of behaviors that health providers are using lead to outcomes of interest. And I think that's where the aspects of AI and machine learning and having consistent data sets and also having comparators that are able to determine where perhaps those practices are leading to better outcomes are going to guide us. Traditionally, I mean, you will know this better than I do. Traditionally, decision support has been very much a linear yes, no. And I think what we're seeing is that there is a predictive nature that is coming to play in a lot of decision support tools that is not necessarily very well aligned with how we develop and release recommendations. We're recognizing that. We know that. We're very keen to work through that and determine how those algorithms might be Bayesian. It might be where there are different levels of influence by different characteristics, can help to inform how we then subsequently release different recommendations. If this is an area that you have expertise, we would be thrilled to talk more. And to those of you who might be interested, we would love to know more about how you're thinking about that. Thank you.
Thank you very much. And I know that we're over time, and I wanted to just thank you all for joining us both online and here in person. It's good to see so many people, and I really wanted to thank the UCSF and Jeremy and George and everyone for making this possible to be here, and to especially for the WHO delegation. We are thrilled that you are here, and thank you. And it's our honor to serve as Secretariat of the WHO Tech Task Force. So with that, stay safe, everyone, stay healthy, and hope to see you soon. Thank you.